4 days, 9 safety experts, 13 presentations, one simple mission: to make diving safer. This is Dan at DEMA 2020. Safety seminars from the pros who know.
So good afternoon, everybody. Welcome to the fourth and final day of DEMA 2020. My name is Steve Jamroz, and I'm the Director of Marketing here at DAN. It's been a great 3 days. The last 3 days have brought us all together, and we've had hundreds of dive professionals, dive businesses, recreational divers participate in our safety seminars. We've had people from all over the world, United States, Canada, the Caribbean, Europe, and it's great to see you all here with us. It's really the passion we all have for diving is what brings us together. And we're going to talk about COVID-19 and diving today. Just a minute, I'm going to introduce Dr. Nochetto, Dr. Chimiak, and Dr. Saraiva, and they're going to discuss our position on COVID-19 and how that impacts fitness to dive. After this session, we'll have a short question and answer period. So please post your questions in the chat area, and I'll pose them to the presenters at the end. But before we get started, let me introduce you to today's presenters. Dr. Camilo Saraiva is our Assistant Director of Medical Services here at DAN. He's a board certified doctor in radiation oncology and hyperbaric medicine. He was the former director of the Brazilian Hyperbaric Medical Society. Dr. Saraiva is also a dive master and former cave diver. We're glad to have him with us today. Dr. Jim Chimiak, he'll be speaking. He's the Chief Medical Officer here at DAN. He's been working with our organization since 1983. He's a board certified in anesthesiology, pain management, and hyperbaric medicine. Dr. Chimiak has worked with NASA and the US Navy and holds Navy qualifications for mixed gas salvage, undersea medicine, and saturation diving. And last but not least, Dr. Matias Nochetto is the Director of Medical Services here at DAN. He's the co-director of the DAN UHMS Continuing Medical Education Program, and he's a faculty member of several national and international diving medicine courses and programs. Dr. Nochetto is a dive instructor, and he has completed a 3-year clinical and research fellowship in hyperbaric and diving medicine. Thank you all for being with us here today. I'm sure your presentation will be informative and enlightening for everyone. So let's get started with Dr. Nochetto. I'm turning it over to you.
Thanks, Steve. Hi, everybody. It's good to see you in a strange DEMA this year. It's been a hectic year for sure, and it has impacted everybody. So let's give you an update on COVID-19 and diving. So we had some short talks over the year with lots of anxiety and how could COVID impact diving. It's a new disease, so we really don't know. I mean, scientists all over the world are learning the disease, and as we learn, we try to extrapolate what we know and figure out how could that impact diving. So now November, we know the disease much better than what we knew it at the beginning of the year. So we have a little bit more answers to give. So let's start with this update. So what is COVID-19? So you all know COVID-19 is a disease caused by this coronavirus. So it means coronavirus disease 2019, and is responsible for the pandemic we're immersed in. So up to this date, 189 countries affected, over 55 million cases, and over 1.3 million deaths. So this is the number of new cases day by day ever since the World Health Organization declared the pandemic. And these are the number of fatalities worldwide day by day ever since this started. So things are not looking good. This is the worst thing that has happened to recent history in terms of diseases and pandemics in the last 100 years. And this is the fellow that is responsible for it, this tiny structure. This is actually SARS-CoV-2. It's a really, really tiny, tiny biological structure between 0.06 microns to 0.14. So to give a perspective in reference with other things that we're maybe more familiar with, so here is the particle, the viral particle, and here is a red blood cell. So if we put this in more mundane terms, if a red blood cell would be the size of a Volkswagen, the coronavirus would be about the size of a rat. So it's really a tiny structure. So what is, in essence, a virus? So a virus is this, it's a submicroscopic pathogen. So it's a particle that you cannot see on a regular microscope. Viruses can infect all known life forms. They are biological entity, but they're not a living organism. So when we say we're killing the virus, well, technically we're not killing it because it's not alive. So these particles, they can replicate inside a living cell. And then what they do is once they get into the living cell, they use the cell and all the metabolism and the metabolic pathways and the mechanisms to create more copies of the virus and eventually spread the disease. In the process, sometimes the virus kills the cell and sometimes it doesn't. That depends on the virus. Now, in terms of viruses, and I'm going through basic virology for you to understand on mechanisms to prevent the infection. Essentially, all viruses, they are either naked viruses, like this one here, that has the capsid and the viral genome, or what we call an enveloped virus, which is essentially the same thing, right? The viral genome, the capsid, but in this case, the virus is covered by a layer, a lipid membrane layer. This lipid membrane layer belongs, or used to belong to the cell that the virus attacked. So again, all types of viruses, they're either naked or enveloped, and here we have them. So we have the first here, they have a lipid membrane. This one doesn't, this one does, this one doesn't, this one does. So why is this important? Because the way we try to protect ourselves from the viruses is by prevention, right? We have talked, and Dan and other members of the industry have talked a lot about ways to prevent infection by sanitizing things, by cleaning things. What we're trying to do with sanitation and cleaning things is to disrupt that membrane and inactivate the virus. That's why it's so important. So this is the membrane. In this case, this animation is a lipid membrane of a cell. So here we have the extracellular space and the intracellular space. These are the lipids. And in the membrane, the cells, they express proteins. So when the virus invades the cell and eventually takes away part of this membrane, it takes it away with proteins because the virus wants to express its own proteins on the surface. These proteins that we see here, those red things, so figure out these things and imagine them as keys. These are the ones that prevent that allow the virus to attach to certain specific cells and not others. Without these proteins and without the membrane, the virus cannot replicate and eventually it dies, quotation mark, or inactivates. So those keys are here, and they are the ones that allow the virus to invade the cell. So when the virus is enveloped, this is the mechanism. And when the virus is not enveloped, it's essentially the same mechanism as before, just without the membrane. One is by membrane fusion, without the other one with endocytosis. So again, the reason why I'm going with this is this membrane. Think every time you're wiping something with disinfectant, what you're trying to do is to disrupt that envelope in the virus so that it doesn't affect us. It doesn't infect us. So everything that I've said so far, this is fact. This is basic virology. So what I'm going to be talking about now is the things that we still don't know because things are changing, right? That's the nature of science. When things change and new evidence shows up, we don't change our mind. We just change direction. In the beginning, we were talking about, the face coverings and yes, no. Well, scientists didn't change their mind. New evidence showed up and now we are recommending them. So, as you already know, the symptoms usually show up between 2 to 14 days post-infection. And again, at this point, we don't need to go over this. Everybody knows how this presents. The serious symptoms usually are associated with trouble breathing, pain, or pressure on the chest, confusion, decreased alertness, bluish lips or face. And we know that contagion usually lasts no longer than 10 days post-symptom onset. The most important thing here to remember is many people are asymptomatic. This is why we ended up in the pandemic. It would be easy to stay away from people that look or show symptoms. The problem is we don't know who is showing symptoms, and they may still have the virus. They may be replicating it, shedding virus and infecting others. Again, that's why we ended up in this pandemic. So how to prevent? We're pretty sure that it spreads person to person. That is why we're recommending social distancing. It seems like the virus spreads more efficiently than influenza, than the regular flu, but less efficiently than measles, which is a good thing. That's why we want to practice good hygiene, and we insist in soap and water. It is important to realize and understand that hand sanitizers, they're not an alternative to soap and water. The best way is soap and water. If you don't have soap and water, then you can use hand sanitizing solutions. That's why we use PPE. We're trying to prevent infection and prevent the spread. Two different things. We'll see that in a few slides. Eventually, we may go into a lockdown or isolation where we have patients with symptoms. But it may also spread via indirect contact through contaminated objects. That's why we wipe everything, right? It doesn't seem to be the main way it spreads, but nevertheless, it's a good way to exercise caution and try to prevent spread. So could there be other ways in which this virus is spreading? Well, there may be. We just don't know yet. Animals to people. There is no evidence, no significant evidence to think that animals can play a significant role in spreading this virus. We know that we can infect some animals, but it doesn't seem to be the main way it spreads. Contaminated food. Well, you could think that if the chef is not wearing protective device, is not wearing a mask, and he spreads droplets over your food, well, that food might be contaminated. Now, the other caveat is, what about temperature? If the temperature of the food is hot, you could potentially inactivate the virus. What about pH? Yes, well, hopefully, if the pH is low enough, acid enough, maybe you are protecting yourself. We just don't know, so it's better to be safe. So in terms of transmission, we have reasons to believe that this image you see here is risky, right? So we all wear masks. We know that these droplets contain a virus, and we think that keeping 6 feet apart seems to be decent enough. Now, the important thing to know about these droplets is, although we talked about the size of the virus being really, really tiny, I mean, very few things, very few masks will be able to keep you from containing something so tiny. What is important to realize is the virus doesn't go by itself. The virus flies person to person on a saliva droplet, and the saliva droplet is much larger than the virus, right? Just to put things in perspective, this is the size of the virus, 0.06 to 0.14. A droplet is between 0.6 to 1,000 microns. So it's many, many, many times larger. So if we can contain saliva droplets, we are actually making a very efficient way to preventing the spread of this virus. So again, why we want to keep distance, right? We know that these droplets can travel up to 6 feet. We also know now that it's not just the droplets, but the aerosolization, all this sort of vapor that we see here that could potentially travel much more than this. Interestingly enough, here in this study, we see that these researchers, they realize that in humid environments, like the ones we have where we dive, where diving is popular, in a very humid environments, this vapor, this aerosolization could potentially spread much longer than those 6 feet we usually recommend. So, good thing to keep in mind. If you live in an environment where there's a high humidity level, you may want to extend those 6 feet a little bit longer. So how do these masks work? So here we have a comparison of 3 different types of face masks. So a folded handkerchief, a homemade face mask, and any of those off-the-shelf cone-style masks, not necessarily an N95. So here we see after a simulated cough, a few fraction of a second and 2.7 seconds after, you still see some water vapor there, right? Some droplets. That's with a folded handkerchief. With the homemade face masks, within half a second, the amount of droplets that leak out of this mask is far less significant. Now, with an off-the-shelf cone-style mask, again, not an N95, with almost 1 second after, there's almost nothing that leaks out of that mask. So what is the big difference here is the snug fit, the fit with the face, right? Very, very few leaks. So surgical masks and homemade double-layered stitched masks are highly effective in preventing the spread. This is key, preventing the spread. Okay? So the more layers, the more effective they are, and with a very snugly fit, that is even better, right? Here we have the classic surgical masks, and here we read not recommended for preventing infection. Right. This doesn't filter the air you breathe. This is meant to catch your droplets, right? And the better fit you have with your mask, the better it contains those droplets. This is the same way we divers were used to, when we insist on divers with oxygen first aid to have a very good seal with the mask on the face. That's what we're trying to achieve here, a very good seal with the face. So 3 types of masks, right? These surgical masks. They're not very good at filtering the air you breathe. They do some, but that's not the main objective. The main objective of this mask is to catch your droplets. So they prevent the spread. That's all they do. The second type of mask, this is an N95 with a valve. So these are really good in filtering the air you breathe, but they don't do much in terms of catching droplets. Why? Because they have the valve. So every time you exhale through the valve. So if you have an infection, you're not doing anything to protect your neighbors. So they protect you, but they don't prevent the spread. And here you have an N95. These are really good at filtering the air you breathe. N95 means they filter 95% of the particles that you could potentially breathe. And they're really good at catching droplets too. Now, unfortunately, they're typically reserved for medical personnel and they're more expensive. So you would say, well, is this better than this? Well, I think this is actually better. You're catching or you're coughing. If you ask me, this is rather selfish. You're filtering the air you breathe, but you're not doing anything to protect others. So think of these masks as a way to respect your neighbors. You're not using this to prevent you from getting infected. You're using this to catch your own droplets and prevent, if you have anything and you don't know, you're protecting others. Yeah, so that's the N95, right? 95% of the very small particles. So COVID on the lungs, this has been the main concern for divers. So like many other viruses, SARS-CoV-2 can cause pneumonia. This is not the only one that could affect your lungs. When the virus reaches the lungs, traveling through these tiny saliva droplets, that's when we get infected. Then the virus invades the cells lining the airways and the alveoli. And like I said before, sometimes the virus kills the cell in this process. When the cell is dead, then it's our own immune response, the one that causes more damage. The symptoms, we talked about that, and the largest damage happens as a result of the immune response to the infection. We have inflammation, and when we have inflammation, we have leakage of fluid into the alveoli, and that is when oxygenation is severely impacted. So what you see here on the left, that is a normal lung. That's how your lungs should look on an X-ray. And what you see here on the right, those are the lungs of someone with a COVID pneumonia. So you don't need to be doctors to realize that this is not looking anywhere near what this one looks like. This is severely pathological. This guy is not having a good time. So this is an echo-enhanced scanning micrography where we see the inside of the alveoli, and we're looking at the capillary bed around the alveoli, and we see the red blood cells going one by one. It's a really, really tiny and thin structure. What you see here on this image, this is the terminal bronchioli, and we see the alveoli and all these structures. So let me zoom in. So this is the alveoli. This is where we have the air. These are the type of cells that the virus likes to invade. And here we have a capillary. What we see here, this is a red blood cell. So between the red blood cell and the alveoli, this is a very thin structure. That is what it takes for oxygen to travel. If you can imagine any swelling here, any inflammation, any inflammatory process that thickens this area, it could severely impact gas exchange. So the lungs are very, very delicate organs. Inflammation can lead to fibrosis and stiffness and areas of poor ventilation. That is why we're concerned about someone recovering from COVID, whether or not they're going to be fit to dive. So this is not good for life. And if it's not good for life, can't be good for diving either. What do you see here? This is a CT, 3D model based on CT scans of lungs with COVID. All the yellow areas you see there, that is pus, that is infection. Okay, pretty bad. So like other respiratory illnesses, COVID can cause lasting lung damage. Important thing to know is the acute lung injury can take several months, not just to heal, but to stabilize. And fitness to dive can only be assessed after stabilization. Just to keep in mind, COVID pneumonia occurs in a fraction of those infected with COVID. If you have had COVID, that doesn't mean that you won't be able to dive, right? Many people have COVID and it's asymptomatic. And many people have had COVID and there's no reason to suspect that the lungs were affected because functionally and with images, they just look and work fine. And the very severe forms of COVID pneumonia are these ARDS-like syndromes, which happens on a fraction of those that have a COVID pneumonia. And with this, I'd like to turn over to Dr. Chimiak to continue with returning to dive after COVID. Jim.
Hello, I'm Dr. Jim Chimiak, and I'm going to go ahead and take the stage here and talk a little bit about COVID and return to dive after a COVID infection. Well, first, I'd like to go ahead and proceed. I'd like to say 2020 has been quite a year. That is certainly an understatement, and there's more to come. It's not over yet. I think as we look back over this 2020 with the COVID infection, it caught us a bit flat-footed. But fortunately, the country mobilized, and we saw a considerable amount of effort from all over the world once the risk was assessed and addressing those issues became paramount. Leaders, and that includes folks from government, healthcare, and divers, were caught in the middle as things were being sorted out, as things are being mobilized and folks were taking care of the infections. You see in the left corner, even the USS Comfort, the Army and the Navy were mobilized during this early stages of the infection. Fortunately, were not needed in the capacity that was anticipated. But it caught us divers and healthcare in a position that decisions had to be made. Things had to still be done, despite the fact that there was no information to guide a lot of things that we were doing. So this was an interesting pull from all these various directions, yet folks had to accomplish their ends. We'll talk, if we have some time, some really good things that folks that had to make those decisions, like the folks down in Sea Base down there in Florida, and as Dr. Saraiva will eventually talk to us about vaccines, which is really the light at the end of the tunnel. First, I'd like to talk about why we're here, and some of the questions that we got was initially that shot that was heard around the world that if you were infected with COVID, you would never dive again. This was shortly followed by the military, who said if you had a COVID infection, you could not enlist in the military. The military rescinded that statement and indeed has taken some of the recommendations of the literature that has been forthcoming. Remember, early in any sort of crisis, folks are going to go toward a more conservative approach, and there's nothing wrong with that, and go ahead and take worst possible case and then go ahead and formulate policy. Unfortunately, this has to be picked through and righted so that a very rational approach to this takes place. So what's been helping us has been the use of the previous infections such as MERS and SARS, which had some fairly significant effects on the population. Fortunately, it did not spread like the current COVID-19 has. But we can take a lot of that information and use that to help us. Getting divers back has been a very interesting problem also, but there is a large body of evidence that's accumulating and has to be done in real time, and that's the return to play. Many of our athletes, both young in school and those in college and those that recreationally exercise, there's a consideration about returning to diving and the effects that it may have on that individual. So return to play is for exercise. It's very helpful for what we're looking at, but it's not diving. As you all know, there's other issues besides just the exercise, but also what involves underwater, and those things being, the actual environment itself, hypoxia, the idea of decompression sickness. So that's launched our Day and Dive COVID study, which again, Dr. Saraiva will discuss later in the latter part of the discussion today. What I've been looking at is the flood of information. Again, everyone's mobilized to help COVID. You can't escape it. And many of the medical societies and hospitals around the world are working feverishly on this very issue. So there's a lot of different organ systems that I've been following. Psychiatric, we all know. There's a lot of things that happen if someone's in the ICU, hospitalized, things of that nature. Neurologically, there's the loss of smell and some neurologic events. The COVID feet, which we'll talk to under hematologic problems. And there's some GI, renal, and musculoskeletal. But for today, we're going to confine ourselves to with this amount of time that we have to discuss, we're going to hit the big ones. And that's pulmonary, cardiac, and hematologic. The pulmonary, of course, is the center stage. That it's a respiratory infection. It's pneumonia. It's a viral pneumonia. So you do see many of the things that have to do with a viral pneumonia. As was very well put is in the previous talk, is the idea that the lock and key, as the virus finds those various receptors throughout the body, unfortunately, there is this receptor that this particular virus likes to latch onto is found throughout the body. That's why we had all those organ systems that we're looking at. So it can cause the primary thing that we all hear about is hypoxemia, and there's a host of reasons for that to occur. And even that is being worked out why we see the happy hypoxemic. There's also secondary infections, and those can occur when you see the ventilation, the quick to ventilate that we initially latched onto, and some of the problems that come on just from being on the ventilator, in which we've understood for years some of the problems that happen there. In addition, there seems to be an elevated risk of coagulopathy and some problems with venous thrombosis and eventually even pulmonary embolism. And in any viral infection or any time anyone's intubated, you always worry about secondary infections, second bacterial infections that can additionally ravage the pulmonary parenchyma. The residual effects are the ones that are most important to us, and that is the ones for returning to dive is the bronchospasm, bleb formation, fibrosis, pneumonia that will impact our ability to return to diving. There's been previous studies that have looked at this about the 3 to 6 months mark, looking at people that were very sick from that infection that had actually developed ARDS. And that's one of the things that we're going to be discussing as far as how we're going to go about it, how we're going to approach, how we're going to determine someone who's fit to dive. The second thing we talked about is cardiac, and that seems to be one that's been come on more recently, looking at some of the issues that surround a viral infection. Now, this is not new. Myocarditis has occurred in many individuals, and indeed, adenovirus, H1N1, Coxsackie, herpes, parvo, and influenza all have been implicated in problems with myocarditis. There's also the cardiomyopathy that we're concerned about that can even cause from either sepsis or from the stress cardiomyopathy. In addition, we're looking at some of the secondary effects, and the ones that we're concerned about is MI and of course arrhythmias, heart failure, of course, and in our case with diving, of course, always is sudden death while underwater or loss of consciousness. Now, there's been some very interesting studies that have demonstrated a fairly widespread incidence of myocarditis and inflammatory findings on these studies. What has not been articulated sometimes when these are put out into the lay press is that these are relatively acute imaging that has occurred, and the idea that this may resolve or get improved with time is up to question, and something that we're following very, very closely, as well as return to play groups that are looking at exercise after such an infection. A very small study looked at cardiac MRI and looking at the incidence of myocarditis and cardiomyopathy in some athletes, and found some very interesting things, that there were a number of the athletes that did have some changes. However, just like in previous studies, in this group, there's not a lot of normative data to go ahead and take a look at. In fact, some of these could just be athletic cardiac adaptation that was actually being seen. This is going to be worked out, and to be able to normalize whether such evaluations are something that are going to bear fruit or overcall problems that are not there at all. The last, hematologic, and you've heard much about these. These are small thrombi that form. There's a heightened coagulopathy that occurs. There's an affinity for areas such as the incidence of problems with small thrombi that occur in the small vessels, and these can lead to either deep venous thrombi or even pulmonary emboli. The vascular endothelium is affected, as we discussed earlier, because of the fact that there are receptor sites in the endothelium, and how that's going to affect decompression later on is something to consider. Again, is this effect going to be long lasting, or will the endothelial heal along with the body? In addition, you have to worry about, again, hypoxemia, and any lasting hypoxemia or any impairment of oxygen transfer, particularly those who are engaged in breath hold diving. And lastly, of course, anticoagulation, the idea that some will remain on some anticoagulants for maybe perhaps several months following their infection, depends on how severe, and following the different parameters. I was going to list this as number 4, but it's very, very important. I think fitness is so important during this period of time. Everyone should be right now practicing to go ahead and get into a quote unquote marathon, meaning that the marathon being that if you should be infected, you will do much better. Some of the parameters have shown. But in addition to that, we need to know a baseline level of fitness that you have now, so that you can compare that to if you were to be infected. Those that are recovering say that this has been very, very helpful to go, what is the level? Have you returned to that same level of fitness or exceeded it, hopefully? And those are very helpful as far as determining your return to diving. Otherwise, we're going to have to rely on normative data, basically what is standard for the general population, or some more involved cardiopulmonary exercise testing that will help determine those. The return to exercise, return to play, that sort of algorithms have been formulated. They've looked at a host of different kinds of studies. They've stratified looking at the severity of the illness itself. And that has seemed to be what's ringing through in many of these algorithms. Various testings have been looked at, looking at either blood testing that look at troponins for heart, their effect on the heart, various imaging studies that have been called for, and various cardiac studies in addition. The previous was discussing in the broad population returning to play, returning to exercise. But a group out in University of California in San Diego actually developed some a very good conservative on the early goings, looked at some of the issues that were coming out and did a very conservative look at that, looked at some of the issues and came up with some formulations of things to look at. Since then, there's been some additional things that have come out that will no doubt be added to that, and some of these may be subtracted. As we learn more about it, the conservatism that perhaps isn't yielding much can be removed, and those important aspects will be added. Now, we always have to include this because if you can test everything and you can go through a whole variety of different kinds of tests, but you have to also be concerned about if you test enough. And as if I may read this wisely, ordering a follow-up test is key to people who have recovered from COVID. Outside of a carefully controlled study, tests should be ordered based on symptoms, signs, and not merely to sate curiosity. At this point, it helps as far as research, but the idea of continuing just doing tests for test purposes yielded that if your doctor has not found something wrong with you, he has not ordered enough tests, and that's a tongue-in-cheek type statement. Even Dr. Charlotte Sadler, in that wonderful paper that you wrote about how to evaluate, their approach to approaching divers, even mentioned that CT may be overly sensitive for clinically insignificant lesions, as well as cause unnecessary radiation exposure and cost. And I just put this picture because the idea is that these kinds of tests, when you go ahead and evaluate a given diver, may yield a quote unquote positive that may make that person unfit to dive. I'd like to introduce just a little bit of a very good event that occurred, and that was down in Florida Sea Base. We had Joe Angelo and Tim Stanfield took the leadership position in this, and during this COVID problem, implemented all the different preventative measures and ways of screening, and an extremely good initial screening before divers even arrived to his site, both medically looking at folks that were fit to dive. When they got there, they again did an extensive screening. They even did functional testing whenever that seemed to be a problem as far as whether the diver was fit and ready to dive. And then strictly in a very regimented fashion, segregated the crews, the boat crews, the groups, and was able to successfully get 5,000 divers and sailors through his program over the summer. And this is spread over the Florida Keys and the Caribbean. And he was using, for 7 to 10 days of camping on liveaboards and barrack situations, and able to successfully do this. So it can be done. So I'm going to conclude by just going over some of the things that we talked about here today. I'm so sorry for how fast we had to go through this, but a lot of stuff had to be covered. And that is, in the pre-infection, this is where you come into play. The idea of weight control, getting your weights down. It seems like obesity has a really strong influence in what happens to someone who's infected. Stop smoking, get that fitness program together, regular and orchestrated, and measure your level of fitness. Prevention, we've talked about this and some of the other talks that Dan has given on how to prevent, how to take care of the surrounding, disinfecting and how to stage your equipment. This is all very, very important. Even that's changing, as Dr. Finelli from NIH just recently, I think the day before yesterday, is challenging some of the things that they're being put out as we speak. The treatment of the acute infection has improved so well. We're getting back to the way we handle pneumonias, and we're implementing those things that we've known about for the last 5 to 10 years. Recovery is a very important phase that's done under your doctor, and ensure that you're doing well, whether it's inpatient or even outpatient. Wonderful programs on the outpatient as far as handling COVID. Then there's the physician team that clears you to go ahead and go back to exercise. And there's some very regimented approaches, perhaps going only 50% initially, and doing this under physician guidance. And then once there is a recovery, a functional recovery, where you have gotten to the point where you're asymptomatic and you're back to full fitness, that's when we see the diving medical physician. At any step here, introduction of any of these tests that are being recommended for specific problems. And then when you get started, do a conservative, be compliant, compliant, with the rules and regulations when you're diving, so that you have no problems with the diving, and you can articulate if you did have an issue while you were diving, that would be stopped, and then the evaluation would recommence as far as bringing you back on board. So at this point, what I would like to do is I'd like to turn the stage over to Dr. Saraiva. He gets to do the good light at the end of the tunnel, and I envy him for the talk that he's going to give, but very, very important to help us all understand the testing and the vaccinations that are going to be that are going to happen. Dr. Saraiva.
Thanks, Jim. Welcome, everyone. I'm glad to be with you here today. It's the last day of the talks, so let's hang up just a little bit. There's a lot of good information to come. So we're going to discuss a little bit today about the COVID tests, the vaccines, and our own then diving after COVID study. So for the tests, there's mainly two types of tests. One test that looks for the virus and one test that looks for the antibodies for the virus. And this is our immune response to the virus. So the first one, the virus test, and keep in mind that both have their own limitations. For the antivirus test, a false negative result can mean that you never had contact with the virus. You had contact with the virus, you were infected, but not long time ago. So not enough time for you to have copies of the virus in enough number to be sampled, or simply that the sampling was not done in a proper manner, or it was a poor sampling of the nasal cavity. Just to be sure, because of some calls that we received asking about this, the test is done through a nasal swab, and this swab is something that will not cause you any harm if done by a medical professional trained for this. The second test, the antibody test, we look for antibodies to the virus. So for this one, if we have a negative test, it only means that you never had contact with the virus, or it was not time enough for your body to produce the antibodies for the virus. So it should happen around 1 to 3 weeks, but you can get this test on the window, and this is a blood sample test. So if you get into this window, you still in a contact with the virus, you had contact with the virus, but you're still in a situation where you didn't have enough time to produce the antibodies. So moving for the vaccine, and probably the vaccine, apart from a cure, it's the most important thing for us at this moment, and something that everyone is trying to get to this vaccine. Several different companies are working on this, and it's a big effort, and it's something that we never seen before in the health industry. The main candidates, we're going to discuss the main candidates for the vaccine and when it might be available for us, keeping in mind that it will be a tiered process. Probably the frontline health professionals are going to be the first ones to receive it, then the vulnerable population, and then the general population. One thing that I'd like to put in context here is that we need the vaccine. No human disease was ever eradicated with herd immunity. So any disease that we eradicated or almost eradicated, it was through vaccination. So what are the steps to develop and produce and deliver the vaccine? First step is to know the enemy, is to study the virus and get his characteristics in place so we can start the second step, which is strategize and produce ideas to fight the virus. And in the third step, we're going to test these ideas. We're going to put in laboratory these ideas to work and see if they are safe and effective. So this is done with human cells and animals. After this phase, once you pass the third phase, the in vitro phase or lab phase, we go for clinical trials. This is normally divided into 3 different steps. And once we have on the final step, we have final results from this vaccine, proving that it's effective enough and safe enough, we can apply for a regulatory approval. So here in the US is the FDA. You have to apply, wait for their approval, and after the approval, you can start producing and thinking how to distribute this vaccine. So just for us to have a good idea of the exceptional efforts that are being put into this vaccine and the warp speed that we're moving forward with this, we had in the past 197 years to isolate measles, 158 years for polio, 11 years for mumps, and only 2 weeks to have the full genome sequencing of the coronavirus. This is really impressive. Talking about the vaccines, we have today 51 candidates around the world for the coronavirus vaccine. Out of this 10 are the ones in phase 3 studies. And out of this 10, we can focus on Moderna and the Pfizer vaccine. This is the real name of the vaccine, but we normally refer as Moderna and Pfizer. So Moderna vaccine, they published last Monday that they had a preliminary results of 94% efficacy and in 30,000 volunteers, all the constraints for safety. Pfizer, 2 days ago, this past Wednesday morning, they announced a pretty significant milestone for us, which is the first vaccine to conclude the phase 3 trials. So the final result was 95% plus effective, and in 44,000 volunteers passed all the constraints for safety. With this, they are promising to have for us around 50,000 doses by the end of this year and 1.3 billion doses by the end of next year. So we're probably seeing vaccinations by the end of this year for frontline health professionals, by spring for vulnerable populations, and by the mid to the end of next year, the general population. Just a little bit now about our study, the Diving After COVID study that we are doing here at DAN. In March, we started planning and designing this study. It's an observational study, so nothing's going to be done with anyone, nothing is going to be tested in anyone. It's just asking and hearing the divers on their experiences, trying to gather enough information to provide answers regarding returning to diving following COVID and possible long-term effects of COVID when diving. So the study will include but 9 different surveys, online surveys. And we started, as I said, we started designing this in March. Just a little bit more than a month ago, we opened for enrollment, and we already have more than 250 divers enrolled for the study. And you need to have a confirmed infection with COVID-19. And we are going to document your recovery time, the severity of your case, your diving practices after recovery, and any medical and health issues that can come from diving after recovery. So as I said, just surveys, online surveys, 9 in total, along 5 years. So you're going to take the first survey that will not take more than 15 to 20 minutes to complete. And on the following 5 years, you're going to have 8 more surveys just to check how are you doing and following up on your case for 5 and it won't take more than 5 to 10 minutes to do the survey. If you need more information, just send an email to covidstudy@dan.org. This is the email specifically for the study, and you'll find information in our website too. Just to show you here some examples of the survey. This is the opening of the survey. So all electronic, you're gonna do in your own pace here, answer the questions. There's some consentment form and all the information for you to consent and participate of the study. And the study is done in a way that you can, at any time, for any reasons, no string attached, cancel your participation. You can withdraw at any moment, no problem at all. All the information, it's gonna be de-identified, so it will be totally private, protected by our systems and with the maximum level of privacy. And the only one seeing this de-identified information will be the staff at Dan Medicine and the staff at Dan Research working with this project. So I'm returning now to Steve to open the Q&A session. And Steve.
All right. Thank you, Dr. Saraiva. That concludes the formal part of the presentation for today. So we're going to open it up for some questions. You can feel free to ask them to the right in the chat screen window. If you've got anything on your mind, please post it there. A couple have come in during the talk, so let's get into the first one. And if we run long, we have a hard stop here at 2 o'clock. We have another presentation. You can always follow up with us either by email, phone, or even through social media. So let's jump into the first question here. Got a question from Dan. Dan asks, what are the potential hazards of repetitive cloth mask use? And if you could elaborate from both a sanitary perspective as well as CO2 retention.
Cloth masks? Did I hear right? The question is about cloth masks?
The question was about cloth masks. So what are the potential hazards of repetitive cloth mask use?
Well, if you think that a cloth mask, eventually, if you're the only one using it, I mean, after a while, could it be nasty? Right, yes, it could be nasty. It's your own germs, so I don't think you're going to infect with anything new unless over the contaminants and over the nastiness and other stuff grows, right? And what was the other part of the question?
Could you elaborate both from a sanitary perspective and CO2 retention?
CO2 retention, I think that'll be minimal. It's more the annoyance than causing hypercapnia, an increased level of CO2. I mean, if you think that surgeons are operating hours and hours with a mask, and they don't become hypoxic or hypercapnic during surgery. So, is it annoying? Yes. Is it a risk to health? No, not really.
I think to add to that is the idea that, again, taking information from things that we already know. We've been wearing masks in OR for ages, and the idea that putting hand to face any contaminated surface, you'd have to assume that because you are inhaling it, that there are perhaps some biologics trapped on the mask itself. If you're handling that, it could be a problem. That's why they always advocate to go ahead and clean these things. There's certain kind of fabrics that work better than others as far as trapping particles and that sort of thing. Some actually act to protect you if it's of a certain ply. So combining that is keep it clean, keep your hands off the face. The trouble is that if you start monkeying around with your mask and it is contaminated like any other surface, and it's around your eyes where you can communicate with the nasal passages, you can inoculate yourself. So I think that's perhaps where you might be seeing some information on that. And I double down on what Matias says. You know, we've had long implants. We'll be in there for 14 hours in the OR or so, and we're wearing masks. And there's all kind of folks with all kind of underlying medical conditions. And I don't see that coming up. The dead space in that is rather small, and again, it's not a sealed plenum, so to speak. So in that regard, CO2 retention would not be an issue. I second on that.
Yeah, you're adding dead space, but it's negligible.
Mhm.
Okay. Thank you, guys. I'm going to take the next one here. We've only got a couple minutes left in the session here. So this question came in from Scuba Ted. Will the recording be available for future reference? And yes, it absolutely will be. This will be posted either to our Facebook page as well as the DEMA page, to be able to view the whole session in its entirety. Next question here, medical question for the team. What are the key recommendations that we should consider to prevent contagion in boats? So we're on the dive boat itself. What can we do to prevent the spread of COVID-19?
Yeah.
I think we have our risk mitigation team has put something together about specifically that. So I would defer to them. If you go to dan.org/COVID-19, I think I put that on the chat. They made some good recommendations on how to prevent in boat operations and so on. And there's no one size fits all answer, right? I mean, different environments may have different approaches. The type of boat, the number of people, the layout, it depends. But there are things you can do, certainly. And it all boils down to most cases common sense.
Yeah, I think that's a good thing. There's a lot of information on CDC. You can use the information there. And as I alluded to today, Dr. Feiner came out today from NIH about looking at, maybe more toward the idea of looking at the aerosol droplet contamination versus what we're seeing for the decontamination of surfaces and things of that nature. So there may be some changes, some small changes in that in regards to that, where we should put a lot more of our efforts. There's people that are successful. Again, I shout out to Joe Angelo and his group down there, is folks that are doing this as far as keeping separation and keeping folks from small enclosed unventilated areas and in close proximity, unprotected from one another. That's probably a key underlying factor. But CDC is constantly updating these things and be on the alert. We were talking about putting the stuff on the webinar as we were discussing, is that be very careful, because this is a very evolving thing. There's a lot of people working on this, and there's some great minds coming in and saying, hey, wait a minute. This is how we handled this before, this proning and stuff. This is standard ICU approach where you're not doing that before. So some of these things, you're going to see good sense prevail, I think, as we move on with the year.
Great. Thanks, Dr. Chimiak. And with that, I think we're going to have to conclude this session. We've got a couple minutes before the next one begins, but thanks to all of you for presenting the information for us. I think it was very helpful for everyone. And but most importantly, special thanks to all the DAM members, the dive professionals, the businesses who took time out of your day to support us and be here with us today. It's through your support that really enables us to do what we do for the dive community. So we appreciate you being here. And just lastly, as a quick reminder, we've got one more session coming up in just a couple short minutes at 2 p.m. Eastern time. We've got Francois Berman presenting accident review. Did your equipment fail, or did you fail your equipment? And at 3 o'clock, our last talk of DEMA, we've got Dr. Tillmans, who will present Listening to Your Heart, a cardiac health research update. So we hope to see you there, but thanks to everyone for your participation, and we'll see you the next seminar, hopefully. Thank you.
4 days, 9 safety experts, 13 presentations, one simple mission: to make diving safer. This is Dan at DEMA 2020. Safety seminars from the pros who know.